Thank you, and greetings from Washington, D.C., the headquarters of the Assistant Secretary for Preparedness and Response. The Assistant Secretary, Dr. Lori, sends her greetings, as well as Deputy Assistant Secretary, Don Boyce. Thank you for participating in our first national call. Medical surge is one of the 8 healthcare capabilities. We are excited to have the opportunity to share with you an innovative approach for implementing Capability 10, medical surge, through immediate bed availability. Today we're going to hear from members of the National Healthcare Preparedness Programs. Let me introduce the speakers on the call. First, we're going to hear from Scott Dugas, the HPP branch chief, who will provide some introductory remarks. Next, we're going to hear from Shane Brannaman, the evaluation branch chief, who will talk about the measures associated with medical surge. Following their comments, we'll hear in detail about the new medical surge model of immediate bed availability from Dr. David Marcosi, the Division Director of Healthcare Preparedness Programs Division, and Dr. Richard Hunt, the Senior Medical Advisor. At the close of the call, we'll have time for questions and answers, and we'll also maybe hear from some of our members from the Medical Surge Function Group. So with that, I'm going to hand it over to Scott Dugas from the Hospital Preparedness Program.
Thank you, and welcome everyone to this unprecedented national call. We're very excited about it to discuss, again, medical surge and more specifically immediate bed availability. On the call today, we have state preparedness directors, state and territory hospital program coordinators, hospital association representatives, and of course hospitals, other healthcare organizations, and their respective healthcare coalitions. We also have our executive working group. Those members are on the agenda as well, and we extend a special thanks to them. And we also want to thank the state and territory public health programs. There are direct cooperative agreement recipients that we've depended on for so many years, and we want to thank them. They're also the point of contact for any subrecipient hospital or coalition for integration and involvement in this grant. As you continue to build healthcare coalitions, build out medical surge and your other capabilities, and begin to operationalize IBA along with your other preparedness capabilities. And especially as you work through integrating healthcare coalition work into your state and local emergency support function constructs. The intent of today's call is, again, information sharing about medical surge and more specifically operationalizing that through immediate bed availability. From a national perspective, we wanted to administer this call with a wide net and have a deep reach approach for all the stakeholders involved who touch the preparedness enterprise and these cooperative agreements. So with that, I'm going to turn the call back over to Mr. Rickett.
Thank you for your opening remarks, Scott. Next, we're going to hear from Shane Brannaman, the evaluation branch chief, to talk a little bit about the measures around medical surge. Shane.
Good afternoon, David, and good afternoon, everyone. It is a real honor and pleasure to be speaking with you today. As some of you know, I am new to the position as acting chief of the HPP Healthcare Systems Evaluation Branch. Fortunately, I have had the distinct honor over the last decade of helping ASPR develop work products specifically designed for use at the state and local levels. Most notably, I assisted with operationalizing the first edition of the Medical Surge Capacity and Capability Handbook, and I am currently serving as ASPR's point guard for crisis standards of care. These past work experiences, working with many of you that are participating on the call today, have helped me think through surge capacity as occurring along a continuum of care based on resource availability and demand for healthcare services. Therefore, when the Healthcare Systems Evaluation Team refined the HPP program measures that will become effective on 1 July 2013, we emphasized and highlighted the preparation, understanding of decisions, implementation of strategies, and stewardship of resources that must occur along the continuum of care. Under the Med-Surg program measure, we have developed 2 indicators specifically associated with immediate bed availability. Many of you on this call, again, helped us refine and hone the language for these measures, and we are very appreciative of your assistance. The first indicator specifically dealing with immediate bed availability is the following. The Healthcare Coalition has tested its coordinated mechanism to both deliver appropriate levels of care to all patients, as well as to provide no less than 20% immediate availability of staffed members' beds within 4 hours of a declared disaster. The second indicator under Med-Surg for immediate bed availability is the following. The Healthcare Coalition has demonstrated the ability to do the following during an incident, exercise, or event. 1, monitor patient acuity and staff bed availability in real time. 2, offload patients. And 3, onload patients. You'll hear a lot more about this information in the following presentation. This topic today is very timely and relevant to our program measures and the nation that we live in today. David, I'll turn it back to you.
Thank you, Shane. Now we're going to hear from Dr. David Marcosi and Dr. Richard Hunt about medical surge and how to functionalize and implement it through immediate bed availability. Dr. David Marcosi.
Yeah, thanks, Dave. Greetings, everybody from Washington, D.C. Thanks for hopping on the call this afternoon. We hope that this is an innovative approach to where we're going with medical surge and the concept of IBA, really the acronym short for immediate bed availability. We'll speak a little bit more about that, and Dr. Hunt, when I turn it over to him, will really try and tease that out a little further. The concept of immediate bed availability is really novel, and it builds on some great work that's been done by certainly a lot of folks in the preparedness sector, and I want to thank them before jumping into our discussion today. Thank them for their efforts. I also want to point out that the folks who are doing the job in every state and our 62 awardees, the fact that they are really good and excellent leaders with regard to preparedness within their respective jurisdictions. I want to pause and thank them for their efforts with regard to shaping the capabilities and helping us refine these performance measures so that we can build on this as a nation moves forward for healthcare preparedness. So with that, I'm going to jump in, provide some overarching context to the hospital preparedness program, our coalitions, because there are folks on this call who really know a lot about what coalitions mean and what that partnership is interpreted as with regard for the hospital preparedness program. And then there are some folks who really are just starting out. So we're going to try and be level setting, so let's get started. So this is a pause on the first slide, an opportunity to have a discussion on weaving a thread of preparedness with the daily delivery of care. That's important, and I'll speak to that in upcoming slides, but I'll reference back to that as we move forward. For those folks who don't know about ASPR, the Assistant Secretary for Preparedness and Response, started as a result of 2002, was codified in language in 2006, and certainly has responded to a host of public health and healthcare disasters, and obviously to date, in 2013, we responded to some most recently. So where are we to date? We stand on a just-in-time supply chain. We stand on a just-in-time staffing model for the entire nation's healthcare delivery system. And that's a challenge when we try to build the concept of medical surge. Those folks who work today, right now, are trying to deliver care for the gunshot wound, the stroke, or the heart attack that just presented to that emergency department. There is not a lot of space within the current system of healthcare delivery today. And that's a challenge for all of us who work in disaster preparedness and healthcare delivery and figuring out what medical surge means. And under that umbrella, how we should be moving forward as a nation in thinking about medical surge. Dr. Lurie's famous for saying if we can't do it today, then we won't be able to do it in game day. Linking the delivery of care systems of what we do right now to what we do in disaster preparedness is critical to moving forward as a nation. And we hope that as Dr. Hunt and I walk through this PowerPoint presentation, we're starting to bridge that gap. So for the folks who are on the call and are watching on this webinar, there's some graphics here, some graphical representations, and if it animates incorrectly, pause for a second because it'll eventually catch up. Your computers will catch up. So the attention of the box on the bottom is really our healthcare delivery system. The preparedness efforts are on the top of that. Our coalitions are partners. Our coalitions are the unit of measure that we're going to be looking for the concept of IBA to execute and implement the the capability for medical surge and the IBA performance measure. So our coalitions are the lighter boxes on top of that big healthcare system capacity and the national capacity for where we stand today. So the truth is, though, if we're a just-in-time system, we may be moving actually away from surge, not toward surge. Our definition of 100% prepared is the ability to be 100% functional, to be able to execute those 8 capabilities that Mr. Ricken spoke to, and I'm going to come back to that shortly in upcoming calls. But the truth is, our system may be moving away from surge, not toward surge. One reference point on that, that's a data reference point. In 2000, the WHO stated that we had 36 beds per 10,000 in the United States. 2006, that number dropped to 33 per 10,000, and in 2012, that number was 30 beds per 10,000. So if that's the case, certainly from a capacity standpoint, we are moving away from surge, not towards it. Understanding that, we now have to develop a construct that bridges what we do today and those realities of healthcare delivery today with what we all think about in preparedness to be able to deliver care in disasters. Everything bubbles down to financials. And this is the reality of the world we walk in with regard to that big black box. That big black box is a 2.5, I think actually it might be larger than that, $2.5 trillion industry. That $2.5 trillion industry is largely a competitive market. Our coalitions, their intention or our intention, and we hope that they actually work in partnership. But recognizing that we stand on a 0.001% of that overall budget, thinking smartly of how we do things, and recognizing that $2.9 trillion competitive industry is something we have to figure out how to partner with, not conflict with, is important moving forward. Because if it all bubbles down to financials, a $347 million program, we can't grant our way to success. We have to leverage the successes that the daily delivery of care is realizing today, right now, with regard to information technologies, with regard to electronic health records, with regard to accountable care organizations. So what do we need? We need a scalable, coordinated system of national healthcare preparedness that meets local, state, and national needs, that links with an ESF8 construct within each jurisdiction. We need to link with daily delivery of care models. We need a financially sustainable approach to healthcare preparedness. And this is what's challenging, this next bullet. We need a population-based healthcare delivery model for disaster preparedness. That means shifting away from an individual-based healthcare delivery system that we stand on today, and allowing a disaster declaration or a declared disaster within a region to allow a pivot point, a bright line that transitions from individual-based healthcare system delivery to population-based healthcare delivery. And as a provider myself, understanding that is a challenge, but we hope today to walk through a little bit more of that. And finally, defining what healthcare capabilities are and the associated performance measures. We're going to speak to a little bit about what 100% prepared means, and if we can achieve those, what then the expected goals are or the targets are. So the National Healthcare Preparedness Program's overview, this is simply for folks who don't know of us, what our mission and vision is. We currently stand on a $350 million program that's intended to be in link with federal, state, and local assets to coordinate a more robust ESF8 structure to realize greater national healthcare preparedness, response, and recovery. So what then are we? What do we stand on as a grant program? We stand on 8 fundamental healthcare capabilities. We're going to talk to slightly today around Capability 1, and there was already a call for our awardees for Capability 1, but we're going to go and jump into the pool on Capability 10. And for those of you who haven't drank your coffee, or those of you who have, you're realizing that that is not numbered correctly. These capabilities are linked with the public health capabilities that our colleagues at CDC have promoted. This is an important point. It's important because preparedness is leading the alignment between healthcare delivery and public health. That point should not be lost. So, there is Capability 6 for the healthcare system of our nation, for information sharing, and our public health colleagues who the healthcare delivery system will not be successful with if not healthcare and public health come to the table and work together. All are successful, or each is successful unless all are successful. That capability is also shared by the public health capabilities and our colleagues at CDC in the Public Health Emergency Preparedness Grant Program. So let's talk about our healthcare coalitions. The whole is greater than the sum of its parts. Certainly, this applies to our healthcare coalitions. The intent is that yesterday, or tomorrow, or today, right now, competitors who compete for hips and hearts, competitors who compete for better care for oncology patients, or delivery of care for dialysis patients today, and they're competing for those patients tomorrow. If they're part of the same coalition, they're working together, assisting their partners in their coalition to be able to affect care so that we have better survivability for our patients when a disaster strikes. That's important. The coalitions are the cornerstone of how the Hospital Preparedness Program and how ASPR is moving forward. We will not be successful unless we have robust coalitions to stand on. Who are some of those partners? Certainly they're listed here, but I'll call out a few. Public health, emergency management, primary care providers. We will not be successful unless those, including emergency medical services, are brought in to our coalition construct and work together to affect care in disasters. This is how it looks today. This is what we hope, and certainly the fact that this stick diagram does not call out all the partners I had listed, I put a strategic pause here. Those lines that are listed are the emergency medical services, the EMS folks around our communities that need to be brought in to the work we're doing with regard to coalition development. Interestingly enough, the insurers are brought in to those discussions with regard to coalition development and how preparedness needs to be better linked with a financial construct moving forward. And that's important for our coalitions to be able to think about as they start to form or make more mature their coalitions within each jurisdiction. So if they are the cornerstone, what should they stand on? We need to make sure our coalitions across the nation are linked with the daily delivery of care. They have a complete and robust functionality and the ability to execute the capabilities. And the capabilities are the ability to put a team on the field. But just because we put the right team on the field does not necessarily mean they'll score, they'll cross the touchdown, they'll cross the goal line to score the touchdown. So our touchdown, our target, is the performance measures. We're going to speak to one performance measure today for medical surge, but that team needs to have complete functionality. Third, they need to be thinking about and adjusting to risk. And risk is defined as those areas that are areas of higher threat. But also, risk is defined as where are our populations more vulnerable. So we'll be looking at that moving forward as our nation's coalitions get stood up. Lastly, we're looking at the percent population that our coalitions cover. And certainly with resource constraint and a $350 million budget currently, we don't know what the future holds. And having the financial understanding to making sure that there's complete functionality of our coalitions and understanding and creating realistic expectations of what each of our awardees can do within their jurisdiction has to be thought about moving forward. And we'll look forward to working with you all as we build those coalitions. And what our expectation is, those coalitions will be able to execute the capabilities and implement and achieve the performance measures, particularly the one on immediate bed availability, which my colleague, Dr. Hunt, is going to speak to, and I'm going to turn it over to him now. Dr. Hunt?
Thank you, Dr. Marcosi. One thing's clear, that without the foundation of strong healthcare coalitions, the challenges of medical surge will not be met. Medical surge, it's an Achilles heel. Medical surge has been a long-standing challenge for preparedness and response, and it's a fault or weakness that causes or could cause someone or something to fail. That challenge, that potential Achilles heel, has been noted most recently in the General Accounting Office report from a couple of months ago. They state, of particular concern are questions about the ability of healthcare systems to surge. That is, to have the staff and resources in place to adequately care for increased numbers of affected individuals or individuals with unusual or highly specialized needs. So, with a persistent challenge, a new approach is needed, a new medical surge approach. Immediate bed availability. Immediate bed availability is actually a phrase that anchors a concept inclusive of not just beds, but all the resources needed in medical surge, realizing it's not beds alone that will care for a patient. Its goal is to quickly provide higher level care to more serious patients during a disaster with no new space, personnel, or equipment. It is indeed, as Shane Bradman mentioned, a HPP, Healthcare Preparedness Program, 2012 Medical Surge Capacity Performance Measure, and the abridged version would be the ability of coalitions to provide no less than 20% bed availability of staffed members' beds within 4 hours of a disaster. Immediate bed availability. It's on a platform that's evidence-informed, operationally tenable, economically sustainable, and ethically grounded. Evidence-informed. One of the real basic concepts that's important to understand is that of reverse triage. And reverse triage is defined as inpatients at low risk for untoward events with a principle of first doing no harm that would be discharged or transferred back to the community. It's based on a study by Kalin in Maryland that had 3 hospitals where they actually monitored their census over a 19-week monitoring period, and those 3 hospitals had 1,632 total beds. The hospitals achieved a net surge capacity of 66 to 81% after accounting for non-disaster emergencies. Importantly, the majority of surge would have been available 24 to 48 hours after the disaster. Operationally tenable. I mentioned it's not just beds alone. Space. Note that every day in our communities, approximately 20% of hospital patients are discharged. And every day, even more patients may be available for discharge. For example, clinically stable patients with few parenteral medications may be appropriate for early discharge. Strategies to expedite discharge may include discharge holding lounges, converting private rooms to double rooms, reopening closed areas, utilizing hallways, converting patient areas to critical care areas, use of temporary external structures, and space such as lobbies, waiting rooms, hallways that can open up as much as 10% operating bed capacity. It's also important to note about space that some of these strategies have actually already been used to decrease crowding in our hospitals. Operationally tenable as reference to staff. Staffing is likely to be the key restriction on the number of patients that facilities and coalitions can accommodate. Coalitions should consider protocols for revision of staff work hours, callback of off-duty personnel, use of non-clinical staff, local medical reserve corps, untraditional patient care providers, surge plans for home care agencies and clinics, and note that fewer larger staffed off-site facilities will benefit from economies of scale. Economically sustainable. How is that? Well, building disaster preparedness into existing healthcare systems makes the process economically sustainable. It allows for surge capacity without extra staff, space, or stuff. Private partners and insurance companies need to be engaged in this process. Billing will certainly always be an issue, but can be mitigated through proactive stakeholder buy-in. Ethically grounded. During overwhelming disasters, decisions have to be made about who can best be served. Medical ethics is grounded in autonomy, beneficence, and non-maleficence, as well as justice principles. The consent to actually be triaged is implicit in the consent to give medical care. It's applied routinely, daily throughout our healthcare systems in military operations, public health, or population-level emergencies. There's certainly the challenges of utilitarian versus egalitarian approaches and the proportionality of care, but note through disasters and in disasters, the victims of disasters need to be considered as equals in terms of treatment, equal to existing patients. Dr. Marcosi used the reference to football games. And I think performance measures in terms of a goal line for a football game, a goal line for this important challenge of medical surge was already described by Shane Bradman, but I want to go through it again because it's important. It is a very long sentence, and I'm going to tease it apart. The percent of healthcare coalitions that have a coordinated mechanism established that supports their members' ability to deliver appropriate levels of care to all patients. It's kind of part one. And one would aspire to delivering appropriate levels of care to all patients, including those that already were in your system, but also disaster-related patients, as well as to provide no less than 20% bed availability of staff members' beds within 4 hours of a disaster. So, I've given you some of the tenets behind this and how it's operationally tenable, but how does it actually work? How can it work? So trying to get beyond the mysticism or myth of immediate bed availability, the next slide is going to give you a construct of a specific hospital, but think about it in the context of all hospitals in a healthcare coalition. Former construct includes medical surge, OB units, step-down units, ICUs, and then we used to think about building additional surge, building additional beds, more staff space and stuff. In our challenged economic climate, that's probably not going to work as well anymore. So moving to this newer construct where indeed you have these same units, but additional surge is built within the hospital and across hospitals in a coalition. This next slide is going to move really fast, so watch carefully. This next slide will show a hospital with multiple patient types, including higher acuity and lower acuity patients. Through offloading to the healthcare coalition partners, for example, long-term care and community health centers and discharge home, we're able to create an increase in acute care space. So watch carefully. Here's the hospital with all its patients, and indeed those with lower acuity who can be safely transferred or discharged home to facilities such as long-term care facilities, community health centers, and again, discharge home. Thus, allowing an institution and across the coalition to build 20% acute care space. The pillars of immediate bed availability, and Shane Bramman also alluded to these. They include continuous monitoring, offloading, and onloading. Continuous monitoring. Maintaining operations certainly will benefit from continuous monitoring. Monitoring patient acuity in real time, absolutely essential when an event happens. And the need to continually establish disaster disposition protocols. That red box there, or red flash, is an event. And it's really important to note that not all events will probably require immediate bed availability implementation. And it's really important to think through the kinds of triggers that will require activation of immediate bed availability. Then offloading. What's offloading mean? Disaster disposition protocols are utilized, rapid bed turnover happens, and discharge or transfer of lower acuity patients to coalition's partners or to home. And then a major issue is making a decision about deferring elective admissions and procedures, and we recognize that has huge economic impact. After offloading, onloading, and quite frankly, that's the easiest part because these patients are going to come at you anyway, and it's going to require redeployment of existing resources to allow for higher acuity admissions. I want to move from pillars of IBA to some real-world experiences. Again, trying to demystify the concept of immediate bed availability. First, talking about continuous monitoring. In continuous monitoring, it's great to have information sharing, but what is the question we're trying to answer in the context of immediate bed availability? And you really want to know, through that continuous monitoring, in a moment's notice, where are the 20% staffed beds? Indeed, healthcare coalitions, greater than half of them, have already started using electronic data and information sharing systems. There's examples of systems out there that have been implemented, and we've noted that in a survey that greater than half of healthcare coalitions have tested communication systems protocols internally and with relevant stakeholders. Communication between coalitions is less prevalent, however, but realize that communications alone, if it isn't able to answer where are those 20% staffed beds, we're going to be continually challenged in trying to figure out how to do immediate bed availability well. Moving to offloading. There is real-world experience with offloading. Reverse triage was actually put into practice back in 2009 at the Royal Darwin Hospital in Australia. There was a boat explosion injuring 30 asylum seekers off the coast. That hospital was full with an emergency department backlog, not unlike what's probably being experienced in many of our emergency departments here in our country today. They had a disaster response team they activated using reverse triage. They canceled elective procedures. Multidisciplinary teams assessed patients. They increased the use of community care facilities, such as nursing facilities, and discharged patients. In 4 hours, they made 16% of their capacity by making 56 beds available. Only one patient returned for further treatment. Notable. Real-world experience with offloading. Hurricane Sandy. This speaks to the foundation of coalitions as absolutely critical to being able to do this. And a quote from that article in the Journal of American Medical Association on offloading: where possible, investments should be coordinated across multiple institutions using healthcare coalitions to ensure resiliency. They noted improved situational awareness, absolutely speaking to the concept of continuous monitoring. They drilled evacuation, and they had measured success in Sandy with transport, which speaks to the issue of IBA offloading. And they also pointed to a need for improved clarity of criteria and triggers for evacuation, much like there is a need for improved clarity of criteria and triggers for implementing immediate bed availability after an event occurs. Offloading. Let's talk about another type of event, seasonal influenza. This past January, during seasonal influenza, we noted expedited case management through discharge planning techniques, decompression of inpatient wards, and isolated hospitals actually did cancel elective admissions and procedures. I'd like to pause for a second here around offloading as it relates to IBA and pandemic. IBA, immediate bed availability, actually attempts to push healthcare systems toward the left-hand side of the standards of care continuum. Again, pushing systems toward the left-hand side of the conventional contingency crisis standards of care continuum. And a pandemic actually may reach a tipping point where crisis standards may apply, requiring, for sure, more staff, more stuff, and more space, and fatality management. So how does immediate bed availability actually apply to pandemic? Continuous monitoring will absolutely be needed across the system. Offloading will absolutely be needed to make space for sicker patients. Onloading will also be needed since sicker patients will need acute care resources. Meeting that 4-hour IBA requirement is a foundation for building surge capacity for events that have much longer time spans. Meeting that 20% staff bed requirement will help, but it may or may not be enough to accommodate volume. We're aware, all of us think about pandemic, particularly in the spirit of the kinds of infectious diseases that are out there right now, and it's important to think about IBA in that context. Moving again to offloading, some real-world experience, and this comes from across an ocean as well. Rashid Hospital in Dubai, they have a 500-bed tertiary care hospital there, among other hospitals in that city. They are constantly over bed capacity. That might sound familiar to some of you on the phone. They actually had activated their disaster plan 10 times in response to real events in 3 years. They noted among those 10 times challenges, commonalities of challenges: lack of bed space, congested operating rooms, uncoordinated medical management. And they did like some of us do and thought something's got to be done, and they did actually a root cause analysis of that. And they discovered that physicians continued with normal business up on ward rounds, doing their usual patient assessments, doing their routine, ordering their routine morning daily chest x-rays for patients in spite of the disaster status. They had no system of recognition of need for reverse triage, and the operating rooms just continued on with routine cases without lack of leadership in this area. So how did they tackle that? They spent a lot of energy with 1-hour meetings with medical teams in individual disciplines on reverse triage education, the principles of reverse triage. They made a conscientious decision in a disaster mode that they would transfer patients to other facilities if specialist interventions were not required within 24 hours or would not be required within 24 hours, again with the principle of first do no harm. And then they worked to increase bed capacity and routinely worked to clear patients through use of hospitalists and extended discharge lounge facilities. They took the concept of offloading a step further And in Dubai, construction is what they do over in Dubai. They spend a lot of energy on construction, and they liaisoned with construction companies, noting that many victims of disasters were construction workers, and they worked with them regarding expatriating patients to home. And they liaisoned with local police to not only allow access to the hospital, but also provide transport escorts. They took it even a step further in offloading, and they developed a mini card. Certainly, this is not the mini card for responders to the emergency department, the casualty department, where the casualties were going to happen. This card, this mini card, was in the pockets of those who were up on ward rounds. The internists, the hospitalists, the infectious disease specialists, those that are attending physicians up on the wards. And these are their medical team member guidelines. And they are very specific in terms of really trying to help them figure out their actions during the disaster. And they have a specific number they can call. They actually tell those physicians, you go up on your units and wards where you have patients, figure out who is possible for discharge, and then they get very specific about how to work on implementing discharge of patients who will not be harmed by that action. Onloading, moving from offloading to onloading. Onloading, it takes place in our emergency departments every day, and it will continue to take place regardless of challenges of space, staff, and stuff. It's what we do. The continuous monitoring and the offloading of immediate bed availability allows onloading to take place in an efficient manner that does not compromise patient care. We're going to do a quick stretch exercise here around onloading. And when I say exercise, it's beyond an exercise, it's a real-world experience. And that real-world experience was on March 11, 2004, where 10 terrorist explosions occurred almost simultaneously on commuter trains in Madrid, killing 177 people instantly and injuring more than 2,000. That day, 966 patients were taken to 15 public community hospitals. 272 patients arrived at the closest hospital between 8 and 10:30 a.m. 272 patients at the closest hospital between 8 and 10:30 a.m. We actually did work to try to sort through, is this a singular experience, or is this experience across the board in international similar events? And lessons learned among multiple medical leaders of responses to explosions that have occurred in Madrid, Karachi, Israel, London, Mumbai, and Delhi found a commonality to the responses to these events. The injured and dead will arrive at the closest hospital, and when that happens, the closest hospital is unable to meet the demand, resulting in the functional collapse of that hospital. It's unable to provide the same services it usually would. Therefore, an absolute compelling need to distribute patients. It is exceptionally gratifying to have watched how we have actually learned from some of those lessons and seen Boston's healthcare system do an extraordinary job of distributing patients among its hospitals. Other recent experiences, and we've had too many, with bombings, explosions, and tornadoes. Offloading, after the bombings, one hospital had 30 patients in their emergency department who were either discharged home or sent up to hospital floors for further workup in 20 minutes' time. 30 patients in 20 minutes' time. In explosions, after explosion, we received a report that nearby hospitals immediately implemented surge plans. They quickly moved lower acuity patients to other healthcare facilities and organized more bed space. Local surgeons were notified that elective procedures may be canceled in the coming days as bed demand warrants. The hospital staff, they said that they were prepared for 20% surge, and they found that through the response, their facility could have surged beyond 20% if necessary. Boy, if that doesn't speak to the issues, and not just issues, but meeting the challenges of medical surge, I don't know what does. In terms of continuous monitoring, we saw a report after recent tornadoes of beds available for bed counts being available for red, yellow, and green categories of patients very shortly after tornadoes had touched down. Again, speaking to the concept of continuous monitoring. Immediate bed availability. Dr. Marcosi alluded to this, the importance of everyday preparedness for game day, and absolute need to weave a thread of preparedness into the daily delivery of care. Immediate bed availability. Further considerations. Realizing we have more work to do and challenges to meet. They include federal regulations, jurisdictional challenges such as triggers, thresholds, when is it that you actually activate IBA, transportation challenges, liability, and staff and public education. We also are aware there are rural challenges to implementation of IBA. But independently of that, medical surge has been a continuing challenge, and this new approach is not only tenable, but it's a practical approach that we already are seeing some really positive, very, very positive recent experience with. So with that, I want to turn that, thank you for your kind time and attention. I want to turn this back over to Dr. Marcosi for further comment.
Yeah, thanks, Dr. Hunt. So, weaving that thread of preparedness in within daily delivery of care, I'll pause there for 1 second. This is achieved if we do this today, right now, with no disaster. If communities are engaged in this idea of continuous monitoring right now, today. If today, right now, there are cards in folks' pockets to understand how to implement this if there's an event that occurs. That means today, right now, our entire nation's healthcare delivery systems understands, appreciates, and can implement a concept like IBA. So let's talk about the measure of IBA for 1 second. The United States changed an entire system of care with the result of one measure. The concept of door-to-balloon time codified and formalized and mandated the relationships between our emergency medical services, our emergency care system, including emergency physicians and emergency departments, our cardiology colleagues, our hospital executives, so that we could provide better care as a nation to victims who are suffering from a heart attack today, right now, within 90 minutes. It is a national standard that when it started was too difficult to achieve. And now it is what a nation stands on to deliver acute coronary care. The concept of IBA mimics a specific time-measured criteria to provide a quantifiable metric that's measurable that we think allows for the better and greater availability of our nation's healthcare delivery system to provide care in disasters. So with that, I want to turn it over to Mr. David Ricken, and I want to thank you for your time, and I look forward to your questions.
Thank you, Dr. Marcosi, for that very informative presentation. Also, Dr. Hunt. Now we're going to open it up for questions. We just went over the IBA and the implementation thereof. Also, we have still here in the room with us Scott Dugas and Shane Branneman for any questions you may have around the measures. And so, with that, operator, can you let the folks know how to ask questions? And then we also have some questions from the chat room as well. So first, we'll open up the live questions, and then we'll be addressing some of the questions that came in over the webinar. Operator.
Okay. So at this time, ladies and gentlemen, for a live question, press the star followed with the 1 key on your touch-tone telephone to be placed into a live question queue. If your question has been answered and you wish to remove yourself from the queue, you can press the pound key. So again, for any live questions, press the star followed with the 1 key, and you'll be placed into a live question queue. Okay, I am showing some questions coming in. We'll take our first from Eric Ofterhide. Eric, your line is open.
Sorry about that. I had the mute button pressed. I have, first of all, I'm really pleased to see the development of the coalition concept, that the problem with uncoordinated care and the coordination between pre-hospital and hospital care has been a problem recognized for many years, so I'm glad that we're making progress on that. I have two questions. One of them is, as was so aptly demonstrated and has been demonstrated by numerous reports in the literature, that most patients end up at the closest hospitals. And to a great extent, this is because most patients are transported by private vehicle as a result of search and rescue operations by private citizens. One of the strategies for addressing this issue has been to designate the closest hospital as a triage and stabilization center with referral and transfer of patients to the other hospitals which have received initially very few patients from the incident. And one of the big stumbling blocks on that is the EMTALA regulations. And I'd like to know what progress has been made to maybe convince the powers that be that there should be a disaster exemption for EMTALA for communities that have developed a holistic community plan for patient distribution.
Yeah, Eric, Dave Marcosi, appreciate the call, appreciate the question. So certainly 1135 waivers have to be thought about with regard to appropriate ability to distribute patients in the event of a disaster. We're engaging currently, ASPR is engaging, and certainly folks down there at CDC, we would be glad to partner with you with regard to this, but engaging our CMS partners and understanding how we execute and are implementing our coalitions, and then therefore they would then subsequently utilize IBA as a tool to be able to provide care for patients in disasters. One of the other tools in that toolbox is the ability to allow 1135 waivers for an appropriate disaster. So we are engaging in those conversations right now, but thanks for the question, Eric.
Okay, my second question is, I've been actually working on a research proposal related to this, and that is the issue of patients with ongoing and chronic diseases losing access to their routine sources of health care. And this may result from infrastructure damage to non-hospital healthcare facilities, including pharmacies, dialysis centers, clinics, and so on. And the concept of doing the reverse triage could be problematic if those non-hospital medical assets were disabled by the disaster or access to them was not possible. And I'm wondering if any efforts are underway to identify how often this occurs in actual disasters and what interventions might be entertained to prevent that, including things like zoning requirements so you don't build your dialysis center in the floodplain, or building codes that would make sure that not only hospitals, but other medical facilities are built with disaster-resistant designs.
Yeah, again, I'll take it, Eric. So certainly continuity of operations is one of those keys, and we certainly, when we have infrastructure damaged, that would impair a facility's ability to continue to function. But the intent is to try and promote a coalition-based focus. And if we have coalitions that are able to better support each other, then they're also able to better provide and support their communities, which means that they would be able to potentially transfer care from a dialysis center that is affected to a dialysis center that is not affected, and to be able to share resources appropriately so that we can mitigate issues like that when infrastructure is affected. For the regard to zoning requirements and things, probably not appropriate for this call, but be glad to talk to you about it afterwards. Thanks for the call, Eric.
Thank you.
Thank you. Operator, do we have any other calls? And again, try to keep them short. We have a lot of folks on the call. Thank you.
Okay. We do have numerous other questions. We'll take our next from Andrew Byrne.
Hi, Dave and Rick. Thanks for your presentation. do you have a mapping of the current healthcare coalitions that have been identified under the Hospital Preparedness Program, and by doing so identifying the areas where there is a gap or need to develop those that would be amenable to new HPP grants?
Yeah, Andy, thanks for the call. If we could ask all the callers when they just identify themselves and where they're coming from, so we know we can just make sure that we're appropriately engaged and giving great direction. So, Andy, I know you well from the American College of Emergency Physicians. So, Andy, we are actually looking at coalition development and actually mapping that out. We're mapping it out with different cross-sections, and I'll let you know some of the cross-sections we're looking at. How accountable care organizations are being stood up, how EMS systems and trauma systems across our nations align with coalitions, how and where our rural partners, our critical access hospitals, align with our coalitions. So we're looking at some of those maps, and we're hoping to provide some of those tools to our ESF8 leads within each jurisdiction to help them think about how to shape their coalitions appropriately, as those really are the leads within each of our 50 states and our other awardees, appropriately figuring out what to do within each jurisdiction. Thanks, Andy, for the call.
Thank you, Dave.
And Andy, this is Rick Hunt. Just to sort of tag team off of Dr. Marcose's comment there, you know, the maps that you're speaking of, one of the things we think a lot about is, if you recall the slide that Dr. Marcose put up there about, it's really important as we think about coalitions that we all think about the percent population served, the risk, the functionality, and healthcare delivery. So when we start thinking about what maps might be most useful, trying to do the kinds of overlays that would speak to those kinds of issues.
Okay, thank you.
Okay, thank you. And our next question is coming from Roy Olson.
Okay, good day. Roy Olson, both with ASTEP and the state of North Carolina. Dave, Rick, thanks for the presentation. And as you outline in your talk, the coalitions are the central key to this entire process. And yet, day to day, we have hospital systems that are locked in mortal combat, with many of them the avowed goal to crush their opposition. And simultaneously, we're asking them to figure out how to play together in the sandbox. Either the system has to have some kind of incentive to force them to play together, because otherwise you're talking about exchanging information that they all feel is proprietary, how many beds might be available and so forth. And we know from experience with prior hurricanes that some systems would never consider loaning staff to help others keep open. How do we change the mindset of the leadership of these hospital systems, very much the way you referred to changing the mindset of doctors on the floor to discharge patients?
Yeah, Roy, way to give us an easy one.
When have I ever done that to you, my friend?
Right, exactly, Roy. So hello to all my friends in North Carolina, by the way. So I think you hit the nail on the head. I think that there's different ways to do this. I don't think we have. There are different solutions, Roy. I think we need all of them in that toolbox, and I'll name a couple. And we're not there yet. First of all, you need some financial incentives. I've said we can't grant our way to success, and linking up with our daily delivery of care systems with regard to how regulations are instituted so that partners who deliver health care, whether or not they be a private institution, academic institution, or long-term care, all have some a shared community interest and a shared expectation that you'll work together once a trigger happens and a pivot point occurs and the community is affected by disaster, and figuring out what those regulations are. And you hate to say the word regulations, but either regulations or incentives to try and encourage them to get there. That's first. Second, I think that there are financial linkages here that if you play, and recognizing there is some competitive nature to the healthcare delivery system, but if you play in partnership, then there is some financial incentive to be able to do that. So not only is it, do you have the, it's a carrot and stick mentality, and figuring out what is in each box. We're sorting through now. The Hospital Preparedness Program, we hope, is the toehold that at least starts that discussion and starts those better relationships forming. Thanks, Roy.
Thank you, sir.
Thank you. And our next question is coming from Paul Weiss.
Hello, I'm from the Southern Maine Regional Resource Center, Southern Maine Coalition of Hospital and Organizations, and I appreciate the talk. I guess my question, that was a great question prior to mine, because selling the idea to hospitals, not just from a competitive standpoint, from a participation standpoint. And the other piece would be the equipment that got our hospitals up to a standard of emergency preparedness has been sort of stopped, and for the last 6 years we haven't had any even maintenance of upkeep of that equipment. And I was hoping to hear if there was any ideas on that or your thoughts on that. Thank you. I'll take it offline.
Yeah, hey, thanks, Paul. Dave Marcosi here. So that's a good question, so, you know, with the shift to capabilities, we stood on the work, the great work that, you know, Scott Dugas and Dave Ricken have been part of the program since when? Since 2004. So they know that the evolving change, the sea change that has occurred from HPP from where it was to where it is. And quite often, there was a lot of buying things, some of them appropriate, some of them were not as necessary. And that shift to capabilities was the hope that, hey, this is not just about buying things, but certainly not, there's got to be an infrastructure component of that, but there also has to be a training component to that. There also has to be special SOPs associated with that. There also has to be regulations and formality that allows those coalition partners, or allows that I bought this widget X to be able to utilize appropriately for staff across a coalition. So we get that there may not be funds needed as much to be able to support that infrastructure, but we hope that there's a change into figuring out what's appropriately needed with regard to infrastructure development, and then building from those pieces of infrastructure what fundamentally are capabilities, and looking at that infrastructure development and linking that with the current 8 capabilities, finding synergies, and then we will support those infrastructure processes and training and SOPs moving forward if they're consistent with the healthcare capabilities. Scott, Dave, any other thoughts? No, we're good? They can't see a head nod, so just tell them.
Yes. Going forward through the capabilities document or our building block approach, certainly equipment purchases are allowable, and as long as they're in line with, we're encouraging that, in line with operational plans and demonstrated in exercises, and if there's a need there, a solid need based on HVA. So certainly the program supports maintaining equipment, any new purchases.
Thanks, Scott.
Concur.
Thanks. John, back to you. Operator?
Okay. Our next question is from Carol Karps.
Yes, this is Carol Karps from New Mexico HPP program. We're a rural state with just 1 or 2 metro areas, and one of the things I'm wondering is when you talk about the measurement being within coalitions, the 20% bed availability within 4 hours, is it possible that we can cross coalitions? If we have a substantially rural coalition that some of our hospitals may be closer to the metro area or get air transport to Albuquerque as opposed to going down to, let's say, Las Cruces in the southern part of the state. And we have like hundreds of miles in some cases between hospitals, and they might only be critical access hospitals. Is it possible that we could do the IBA across coalitions, not just within coalitions?
Hey, Carol, thanks. Marcosi here. So the intent is to do it, and this measure is for coalitions specifically. And, what we like about the measure is that it is, regardless of size of coalition, applicable. So if you have a coalition of 100 beds, 1,000 beds, or 5,000 beds for acute care patients, that measure can be utilized for any of those size of coalitions. Now, recognizing that some of our rural, and we're working through some of the challenges that you all face with regard to the delivery of care in a rural environment. And we're going to be working through exactly what cross-coalitions means, because we want to be very specific and precise on the measure, but allow also appropriate care for individuals. So we don't want to be, we want to be as supportive to our jurisdictions and thinking about creatively and innovatively how to appropriately make this measure count so that it saves lives. And that fundamentally is truthfully the only measure that I think about with regard to this job. So Dr. Hunt, did you have something?
Yeah, I think keeping the measure is important. That being said, clearly there will be disasters that are going to end up, just because of the scale of the disaster, will actually end up crossing a coalition boundary. And, in a recent survey that we did, there has been communication between and among some coalitions. And that, when Dr. Marcosi says we really do need to keep the performance measure intact, but that does not preclude ultimately there will be times of need where people are going to have to go across a coalition to meet a community's needs. So, and also, I did mention in some of the future considerations that rural issues are ones that we all are going to need to look hard and long at to sort through how to best make the kinds of approaches to the challenges that you mentioned.
Yeah, let me just put a foot stomp on what Dr. Hunt just said. So, when we talk about formalizing these coalitions and making them functional, the intent is to try and institutionalize that, make them 100% functional so they're able to work amongst themselves, and then they can work between themselves so that we actually truly build a local, state, regional, and national asset that we could utilize for a small-scale event or a national event like a nuclear detonation. And that's the intent, to try and figure out that pivot point. And we build not just a national disaster medical system, and those folks who are from the NDMS, kudos to you for being on the call, but also we build a national disaster healthcare system that supports and links with our colleagues from NDMS. So thanks for the call, Carol.
So,
Thank you very much.
Thanks, Carol. We're going to go. We have a couple questions that came to us through the webinar, so we're going to pause for a second, answer those questions, then come back to the live questions. So, Dr. Hunt.
Yeah, we had a question from the chat line. Do any hospitals, the question was, do any hospitals that you know of use standardized discharge orders and instructions to offload these patients to healthcare coalition partners? And my inference with the question is, I'm assuming the question was in reference to standardized discharge orders in the event of a disaster. While I am not aware, and I'm not aware of anyone in the program, and people can nod their head if I'm wrong, but of us being aware of that kind of standardized discharge order, but indeed, that kind of thing, models and templates for discharge orders that could be used in potentially an abbreviated format, those kinds of things need to be the kinds of things that need to be considered in essentially a toolbox toolkit for actually implementing this. And that was specifically the reason why I chose to include in the slide deck the slide that showed the pocket card for disaster response by the clinicians who were attending up on rounds on the floors. That's the kind of tool that will actually help with offloading that we had never ever thought about before. So again, I think the question's particularly pertinent in that people need to start thinking through with us, in collaboration with us and your partners and among your coalitions in your states, about the kinds of things that will help you actually get this done. So thanks for the question. It really was a good chance to highlight that.
Thanks, Dr. Hunt. So, operator, we'll go back to the live questions, and then we'll have a couple other chat questions later. So,
okay.
Live questions in the queue?
Our next comes from John Cutler.
Go ahead, John.
Thanks. Yes, thanks very much. We here in Nebraska are a rural health coalition with SEMERS, Southeast Nebraska Medical Response System. The question I have deals with your slide number 13, which doesn't indicate that public health is involved with the hospital model. We certainly use them a lot, and they would actually provide some additional beds or help in terms of a severe situation. Can you comment on that? Should we include public health in these plans?
Yeah, John, thanks for the call. And if let me just stop here. the critical three that are instrumental with regard to our coalition development are 1, healthcare partners, 2, public health, and 3, emergency management. Those 3 are critical to the success of our coalitions, and we're going to be looking at, as coalitions are formed, to make sure that those partners are at the table. I included EMS, and that one slide I said public health. If it wasn't listed on every other slide deck that we have here, it is listed, so some reason it might have dropped off, but that was certainly, and I put a foot stop on this, certainly not the intent. The only way we are successful is if public health is at the table, part of what we all do with regard to coalition development. So thanks for the question, John.
Thank you. And our next is coming from Robert Perry.
Hello. So Robert Perry, University of New Mexico Hospital. So my question is that is there any talk of making it similar to the 90-minute rule for door-to-balloon time a patient safety goal? Because historically, unless regulated to do so, hospitals have kind of said, even with financial incentives, have said, okay, put it on the back burner.
Robert, wow. So very interesting to think about how this links with patient safety. We think that may be some food for thought for future. I think that as IBA continues to unfold, that the implications to be able to provide better care for victims of a disaster appropriately, either in a moment's notice for events like bombings or long-term events, I think that if and as this continues to evolve, could and should be looked at as a patient safety issue. But I think that as we're starting on this road, I want to just say that for right now, we're taking this charge within the hospital preparedness program. As we continue to evolve, we're going to start to look at that other opportunities for engagement. So thanks, Robert.
Thank you. And I'm showing just one final question from the live queue from Kathy Silvestri. Kathy, your line is open. If you would check your mute button.
Yes, hi. Thanks for taking my call. I'm actually a regional healthcare coordinator from the Northwest Ohio region, and I'm kind of looking ahead where you were talking about the fact that we would need to test the coalition's ability to meet this 20% IBA standard within 4 hours, and also to provide patient care to both inpatients and those other patients that we've onloaded and offloaded. Do you have any ideas about how we would document, or what kind of documentation would be required to be able to fully assure you that we've met these standards?
Yeah, so those are some good questions. And the documentation piece, first of all, you know, one of the things, and we were just, Dr. Hunt, actually, Scott, Shane, Cynthia, we're all at the AHA meeting, and one of the questions that was brought up was, do you execute this 20% diuresis immediately after an event? And the nice part about the ability to execute IBA is that piece of continuous monitoring. So that does not mean we have an event, we ought to completely offload 20%, and we just wait with open beds, waiting for patients to come on. This is the ability to bring on patients, and as they're brought on, appropriately be able to offload those patients. If you know that there's 50 from the event, 20 are coming to you, you can offload 20. There may be 10 that are additionally coming that you could wait on, but this is not that immediate offload piece that everyone thinks about when they think about, I need to push the button, 20% of my coalition goes out the door, and now wait a minute, my CEO is not going to like the fact that I have open beds within my coalition. So that's why weaving that continuous monitoring piece within daily delivery of care is important. Number two, the ability to rack and stack and track the disaster patients who are presenting to a coalition is important. So certainly there is ability as patients present to coalitions, as patients present to facilities, to tag appropriately those patients who are from the disaster. So from a documentation standpoint, for the ability to provide care, really shouldn't change. You're providing care for the pneumonia yesterday, now you're providing care for that disaster patient today. No documentation really changes with regard to what we're speaking to. We're really thinking about operations on how to efficiently care for those patients who are presenting. If you're talking about absolute numbers and the ability to document absolute numbers, then that ability to tag patients from the disaster that are coming in and understanding how many are within your coalition will be looked at in retrospect to look at from an absolute number standpoint and documenting appropriately that you're able to assume those or able to accept those numbers of patients to that coalition. Kathy, does that help?
Yes, I believe so. So it sounds like just the ability to use your established patient tracking system to track the actual disaster victims would be one way to do it. And then those exercise participants, if they actually track then the number of patients that they were able to, like the beds that they were able to make available, like track the methods and the numbers, like if it was an early discharge or relocation to another facility or whatever. Sounds like that's what the kind of thing you'd be looking for?
Yes, Kathy, that's right. That's exactly right. So across a system of care, not just a bolus to the emergency department, but this is across a system of care. So that means if you're tracking from you offloaded your 90-year-old with a urinary tract infection who was just switched from IV antibiotics to PO antibiotics and started on Jello, that patient could potentially, with appropriate waivers, and those waivers are, we're tracking on that 1812F waivers, to allow that rapid ability to shift to a long-term care facility that is engaged with your coalition, that understands that's part of your operating principles, that we may be accepting this 90-year-old into our facility, that your ability to track those patients through time is important, and that's what we're going to be looking at as far as documentation.
Thank you very much.
Thanks, Kathy, for the question.
Thanks. So, operator, we're going to take another question from the chat from the webinar, and then we'll come back. And we're going to wrap it up pretty soon. We're going to stop right at 3:30, so we'll address one more question from the chat and then one more question, live question, and then we'll wrap it up.
Okay. This question comes from James Augustine. Please address how this plan interfaces with nursing homes who have a significant role in offloading hospitals and yet are not able to manage many day-to-day roles effectively.
Yeah, so thanks for the question, Jim. So that's an excellent one, and certainly there was just a recent, I think, OIG report around how long-term care needs to come to the table and should appropriately be resourced to be able to think about emergency preparedness for, number one, their staff, number two, their patients, and number three, from an operations standpoint, how they would be able to ensure the continuity of operations for their facility. So to that end, you know, we're looking at how our coalition's partners engage long-term care. We certainly are, that is part of our look towards the future. Traditionally, we have been a predominantly hospital-based system approach, but we're looking at, we are not successful from a individual facility-based approach. We've recognized the subject matter expertise that's on this call. Certainly, a host of evidence supports that a shift to coalitions is important. As we stand together, we are stronger. So to that end, including and appropriately resourcing and engaging long-term care facilities to be part of coalition development across our nation is needed as we move forward for the hospital preparedness program and the development of these coalitions. So we're going to be looking at that. It may not be completely baked yet, but we're putting all the ingredients together to make sure that they're appropriately engaged. Thanks, Jim, for the question.
Operator, do we have any other questions in the queue?
Yes, we do have a couple. We'll go ahead and open Cheryl Grantham's line.
Okay, we'll take two more.
Yes, hi. A very quick question to wrap up. Greatly appreciate the presentation. Can you remind us all how we can get access to the slide presentation that was used today, please?
We're discussing that. We anticipate that we may have a link to the web meeting so that you could go through this presentation in the future, and we're discussing the availability of the actual slides. To be determined, but it will be sent out via the channels that the meeting notice came out, and also to any participants who provided their email address on the website.
Thank you.
Thank you. And our next is coming from Erica Henry.
Hi, I'm calling in from Eastern Washington State here. I really love the approach that the presentation got started off on with sustainment of healthcare coalitions, and I think, Dr. Marcozzi, you used the phrase, we can't grant our way to preparedness, and it sort of gets at a discussion we've been having around how do we sustain our healthcare coalition in the face of diminishing funds and that sort of thing. During your presentation, during all the presentations, but Dr. Marcozzi, you in particular, you really put words to a lot of the financial implications or financial benefits of being engaged with healthcare coalitions. And it just sort of got me wondering, is there a marketing sort of toolkit or some piece similar to that that's available to healthcare coalitions as we start engaging our partners in discussions? And I know not everyone's going to do this, but we are thinking about engaging our partners in discussions around sustainment beyond what ASPR may be able to provide.
Yeah, Erica, thanks. Yeah, I like that a lot of things bubble down to finances, so I appreciate the question. So there are a lot of different reasons to engage in coalitions. Within each jurisdiction, we're finding different models to coalitions. Some of our coalitions across the nation in Florida, in Seattle, in Indiana, are actually forming their own robust ability. Without the grant, they would be able to have some sustainability for their coalition. The importance of thinking about sustainability for coalitions in light of the fact of diminishing resources, I can't put an exclamation point on enough, Erica. You highlight the fact that financially we have to start to think about that, and that's why the importance of linking with daily delivery of care is so important. That financially sustainable $2.9 trillion infrastructure, linking with electronic health records, with duplicity, with working with things in the cloud, so that we saw some of the success that happened in Joplin and their ability to care for patients because they had the ability from an electronic health record standpoint to look and provide the ability to, after their hospital went down, to stand up a new facility that had the ability to access those electronic health records appropriately. So that's the success story, but that requires thoughtful look at whatever is being instituted within different healthcare coalitions and facilities, to have a perspective and eyes to, well, how does preparedness link in with what we're doing now? And not just electronic health records, not just IT systems, but overall operating procedures, billing procedures, regulations, legal ramifications to what they do to codify the work that we're moving forward with coalition development. So certainly there are financial pieces, but there are regulatory pieces, and that last slide that Dr. Hunt spoke to of, what was it called, further considerations?
Further considerations.
Yeah, further considerations. We recognize that this is not, we are not 100% there, and what's interesting is each jurisdiction's got their own set of challenges. So there's not one quick fix that we could profess from Washington, D.C. that's applicable to New Mexico, just as it's applicable to Nebraska. And we have to work with, and we want to work with each ESF8 lead within each state and each jurisdiction and city to make sure that it's appropriate to those ESF8 leads that we can help and support their concept of what coalitions look like to the future, and particularly in and around the concept of sustainability for the future. So, Erica, thanks for the question. Very insightful that you're bringing that up, and we hope to work with everybody on the call to think about that moving forward.
Thank you, Dr. Marcosi. And with that, operator, we have 3:30. Do you want to say last remarks, Dr. Marcosi, and we'll wrap up the call?
No, so Dr. Hunt and I and this team here, I can't thank enough. It's easy to stand and walk through the PowerPoint, but you stand on the team that you've got. And this has been a great team. We look forward to, and I say team, I also include the work group that supports the hospital preparedness program with Linda and name some of them, Scott. Certainly there are others. With John and Linda, Timothy McDonald, Mary Keating, other folks from who help and support the hospital preparedness program moving forward. Cynthia Hansen, who's been really an expert with regard to where she was in measurement and now has moved to a special advisor to me with regard to thinking about, and one of the things I want to make sure I call out on this call, and thanks for giving me that final concluding remarks, thinking about how our coalitions address things like, are you ready for it, pediatric issues. Dr. Hansen was previously in a prior life a child psychologist. She's going to be helping the hospital preparedness program think about how we address things like special needs populations. So to that end, I am thrilled that all of you hopped on the call. This is the first, I hope, of other engagements, and we have the opportunity to do so. I want to think about that we have a coalition meeting upcoming. Is that right, Dr. Hunt?
December. I believe there is a meeting. It's not our meeting. It's the coalition's meeting.
Oh, the coalition's meeting. Sure, in December. Upcoming, and that's going to be where, Scott? Louisiana, New Orleans. So we'll be talking about a lot of this further moving forward, but I want to thank everybody for the call and also thank our CDC colleagues who have been at our right hip through all of this. We have not been successful because of the healthcare institutions standing in isolation. The way we've been successful is that our public health colleagues have come to the table, helped shape the deliverables of our capabilities, helped shape about what we think about those performance measures. So I want to publicly thank Chris Cosmos, Jeff Bryant, Steve Bodenheimer from the CDC Public Health Emergency Preparedness Grant Program. They have really been colleagues and have made us think hard about what we're doing and make sure we're in partnership with how we move forward as a nation for health preparedness, both public health and healthcare delivery. So I want to thank you all.